Can I take a poll on who's a healthcare provider and who's a consumer? Healthcare provider. Okay, so I'm going to skip a couple of the slides, and there is a handout available at the registration for whoever wants to get more information. So let's start with, I have no financial disclosures to make. I am not involved in commercially. I have no interest, and the only non-FDA approved uses are my mentions of medications that are currently used to treat osteoporosis, but for the specific indication of osteoporosis diffuse osteoporosis associated with paralysis. Postmenopausal osteoporosis is an entity that is recognized and treated. Diffuse osteoporosis is a disease that is just raising its head up, and people, healthcare professionals, learn that actually there is a need for monitoring, figuring out what's happening in the bones in people that don't do weight bearing on a habitual basis. So the data that exists in clinical trials is in the category 3, 4, and 5. That doesn't mean that it's not an entity. It just means that we didn't get to studying it. A couple of things about bone mineral density. Density is basically mass over volume, and the density accounts for about 75 to 80% of the bone strength. The peak bone accrual rate of bone is at puberty. Actually, 26% of the bone mass is accumulated in an interval of about 2 years. The peak bone mass is in between 18 to 35 years of age, which happens to be a very common age for paralysis, traumatic paralysis. I think that 38 years of age is the mean age for traumatic spinal cord injury in United States. After 40, normal individuals performing weight-bearing activities lose in between 0.25 to 1% of the bone mass. The cancellous or trabecular bone mass is the loss begins in the third decade. The cortical bone loss starts in the 50s. The bone turnover is about 8 to 12% per year, with cancellous bone turning over a little bit more quicker than the cortical one. What is important for bone health? Calcium, vitamin D, exercise, and diet, especially protein. About 45 individuals per 1,000 experience impairment of their lower extremities. The spinal cord injury, traumatic spinal cord injury incidence is about 10 to 12,000 new injuries per year in the United States. Up to almost 40% of them will have a pathologic fracture being defined as a fracture that occurs on an abnormal bone background. That is during their lifetime. Actually, the studies went up to 30 years after the original event. The bone mineral density fracture threshold is estimated about 50%, so loss of 50% of the bone mass will increase the incidence of pathologic fracture. The disuse, or how I call it, neurogenic osteoporosis, has a couple of mechanisms. First, the metabolic and the hormonal alterations that is characteristic to the postmenopausal entity, but it also has a mechanism that involves the imbalance between osteoclasts, which are the cells that destroy the bone, eat the bone, and osteoblasts, which are the cells that create the bone cells. And why is this occurring? It's occurring because of the unloading that occurs in paralysis. The role of mechanical stress on bone on bone mass, on bone production, on bone remodeling is more than well proven in postmenopausal osteoporosis and in normal population. In disuse, the neurogenic osteoporosis, there is this reduction of forces, of loading forces, that create a cascade of neurogenic, vascular, and metabolic changes at the bone level that together work in basically using and decreasing the mass of the bone, but also creating a smaller amount of bone. So there is this imbalance in between production and destruction. There are markers that can be used clinically, in clinical practice, to figure out which part of the process is more affected. The bone resorption or the bone generation, the bone formation. And if you are interested in those markers, they're on the, in the handout. The metabolic influence, so we talked about a little bit about the imbalance in cell generation. Now the metabolic component has to do with calcium, parathyroid hormone related changes which spill into the hormonal milieu, phosphorus, and 25-hydroxyvitamin D. Calcium per se increases the bone mass and reduces the remodeling of trabecular bone. Why is that important? It reduces the remodeling of the trabecular bone. It's important because the remodeling occurs through small pits, small little bites into the bone. And if the balance in between formation and destruction is impaired, the calcium influence on remodeling actually increases the loss of bone mass. In traumatic spinal cord injury, and I apologize, but majority of the data that I have here is related to traumatic spinal cord injury because the truth is paralysis, weightlessness, so spatial research in the spatial shuttles, and disuse in the sense of immobilization through bed rest are the most practical methods of studying bone mass and osteoporosis that results from unloading. So majority of the data comes from these three different aspects. You won't have trials. There are observational trials, and there is data collection from large numbers of patients that visit a certain clinic that talks about demographics of bone loss, but not about pathology and about interventions. So in spinal cord injury, in traumatic spinal cord injury, there is a significant negative calcium balance, about in between 100 and 150 milligrams per day in the first 1 to 1.5 years. The serum calcium actually can be elevated in the first month, and individuals that have a high bone turnover, which are adolescents, especially male adolescents, can suffer from hypercalcemia at the beginning, but they revert to normal at 6 months. Vitamin D, which is measured, the stores of vitamin D are measured as 25-hydroxyvitamin D. 50% almost of patients admitted to rehabilitative environment have decrease in the stores, in their body stores of vitamin D. So you'll see at the end, my prescription for bone health includes measuring the stores. As far as I know, very few people in actual clinical practice measure vitamin D levels, and very few people counsel patients on the adequate daily intake or treat deficiencies. Vitamin D, not only that it influences the bone mass through a hormonal mechanism, but it also influences directly, it decreases muscle strength. So deficit of vitamin D decreases muscle strength and increases risk of fall. This is a trial done in postmenopausal women. The hormones that play a role are the parathyroid hormone. There is what we call a secondary hyperparathyroidism. That means that parathyroid hormone level increases as the chronicity of the paralysis occurs because of low vitamin D and because of low calcium. Calcitonin just is elevated at the beginning, but reverts to normal at 6 months. And then the role of androgens and estrogens. Well, the estrogenic role is related to mostly to age in females, but in spinal cord injury, which is a disease, the traumatic spinal cord injury is a disease of the male, actually 1/3 of individuals end up having hypogonadism as evidenced by testing free and total testosterone. And hypogonadism has at least two other roles, play two other roles in muscle mass, decrease in muscle mass, and then sexual dysfunction. Low testosterone level in neurologic disease, in Parkinson and Alzheimer, related to cognitive impairment. So the awareness of the hormone level, which can be, again, identified on a clinical basis and should be part of the annual workup, is important, and then the replacement is also a thing that needs to be considered and doesn't always need to be delegated to an endocrinologist. And shortly, where is the biggest bone loss? Obviously, it's in the levels below the injury level, so pelvis, knee, and hip. The fracture, the paraplegic fracture, a term coined by Dr. Ragnarsson in the 70s, occurs around the knee in patients that are wheelchair dependent, so in the distal femur and proximal tibia. The lumbar spine in patients that are primarily wheelchair users, the spine bone density actually does not decrease. Let me see if I have here, but in the study that was conducted by Dr. Garland in 2001, it's only on women with spinal cord injury, but if you really look, women under 35 have no or slight loss in spine density. 30 to 50, actually the spine density increases by 10%, and after 50 years old, it's as measured by DEXA, it's increased by 25%. But where does the loss occur? At the knee and at the hip. In patients that have impairment of their upper extremity, there is loss of bone mass in the radius and in the ulnar. And again, in my prescription for bone health, typically when somebody goes and has a bone density, it's done to the hip, to one hip, to the lumbar spine, and rarely, or maybe they have Colles fractures, they do have wrist bone density evaluated. Well, in patients that have tetraparesis or tetraplegia, wrist bone density should be evaluated on a yearly or every 2 years basis. Bone loss is dependent on how high the injury is, how complete the injury is, so how much movement below the level of the injury you have. Body mass index, you start with a bigger body mass, it's a better thing. Male genders, guys do a little bit better than women because the hormonal milieu is more active in osteoporosis. Obviously, dehydration and prolonged immobilization also play roles. Now, what does exercise do on bone? We have a problem. How do we address it? We address it with whatever therapeutic modalities are apparent to work, or we're hoping that they would work. And the data that I have here, the effect of exercise on bone health, it's mostly from normal population, non-neurologically impaired, because the numbers of disused neurogenic osteoporosis individuals didn't hit that critical threshold in which people will fund and sponsor big trials. These trials are long-lasting because we're talking about bone health. And on average, you start with 2 years, but you follow population for 10 years or more. These are very hard to do. So I'm going to talk just a little bit about the effect of exercise in the regular population, and I'm going to mention the American College of Sports Medicine recommendation for regular, non-neurologically impaired individuals. And then I'm going to ask if anyone here has a problem with applying those to neurologically impaired individuals. So loading per se has an osteogenic, that means production of bone effect, if the stress to the bone is unique, variable, and dynamic. That means the same type of stress, meaning sitting in the wheelchair in the same position all the time, will not increase the bone mass. Needs to be variation in load, cycle number. If you do a cycle of repetition of bone loading, if you do 15 in a row with no rest, is less effective than if you do 5, 5, and 5 with rest period in between. Only the sites, the skeletal sites that are exposed to change in the daily loading force undergo adaptation. So if you do upper extremity strengthening, basically will affect whatever the structures that you involve. You don't expect your tibia, if you don't use your legs, to increase the bone mass. Continuous adaptation requires progressively increasing load. And we all kind of agree with that. Basically, we all vary the amount of activity for whoever exercises, and we measure our success by increasing the load or the time. The benefits of exercise disappear if the amount of exercise is reduced. Obviously, this is just a statement to remind us that physical inactivity per se, without neurologic impairment, is a risk factor for hip fractures. What do we know about effect of exercise in spinal cord injury and paralysis? Very little. I have 2 lines. Weight bearing, maybe it decreases hypercalciuria, so calcium loss in the acute immediate post-spinal cord injury period. And then we have some data about FES, which is functional electrical stimulation, prevents bone loss, but this is a case study. In chronic spinal cord injury, we have a little bit more information, but the information is controversial. Standing per se in a standing frame has no changes on bone density or on calcium loss. But tilt table and ambulation does reduce hypercalciuria, so that calcium loss, the 100 and 150 milligrams per day in the first 1.5 years, is positively affected. We do know more about FES ergometry, the functional electrical stimulation ergometry, and electrical stimulation against resistance. But we know in some studies there is no change. In some study there is less bone loss than predicted. In some there is a positive trend in the lumbar spine, and then we have some studies that truly prove increased bone mineral density. This looks fairly weak if we look at this. you have to remember that even the big studies on postmenopausal osteoporosis, very few of them show increase in bone mass. Majority of them show a leveling of the bone mass. So if you take in the context of what we know about the big subject, this becomes significant. Now, FES ergometry, which has the most amount of data here, is also applicable to only a very selected population category. Not everybody can get their muscles stimulated with electricity and tolerate it. And I'm going to say that probably in this audience, with less sensory impairment or with neuropathic pain, that might not even be a tolerable intervention. So, let's see. Yes, this was the ICSEM, the American College of Sports Medicine position on physical activity in bone health. And again, this applies to general public. It doesn't matter if we have an impairment or a disability or not. This is general recommendation. This was published in 2004 that we all should adhere to. What kind of exercise? Weight bearing and endurance activities, combination of 30 to 60 minutes, 3 to 5 times per week of the weight bearing, 2 to 3 times per week of the resistance, intensity moderate to high. Well, can't be really applying some of those in patients that have paralysis. So the importance of studying specific individual diffuse osteoporosis models becomes a lot more acute. There is data that applies to meningomyelocele. There is data that applies to spinal cord injury. There is really no data that applies to transverse myelitis or multiple sclerosis. So I'm standing here in front of you saying that bone mineral health is important, but truly I don't know how to treat it from controlled studies. I can only use my experience and ask you to bring it up in your own medical community, bring it up as a true entity, disease entity, and voice, look at my bone density, look at the studies that are out there, see what applies to me. One thing that it is known is that the muscle mass influences the bone mass. So the better muscle mass is, the better bone mass. And it has to do with the loading, but it also has to do with this, the fat. Fat has an estrogen-like quality. Estrogens are good for bone. So hormonal milieu plays a role in this too. But body mass per se, fat-free mass, and muscle strength all correlate with total and regional bone mineral density. Fat-free mass being the one that correlates the strongest. What we know from paralysis, for exercise in paralysis, is that FES and electrical stimulation does increase muscle mass. We conducted the clinical, it was a retrospective study. It was in that very weak category. We did have controls and subjects. Our controls were non-exercise individuals with paralysis, and paralysis, actually this weren't only traumatic spinal cord injury, this was neurogenic paralysis. Majority of them were spinal cord injury, but we did have some transverse myelitis and some multiple sclerosis individuals and some cervical myelopathies. So we looked at, and the subjects were individuals that were at least 6 months or more out of their injury, of their neurologic injury, and underwent 6 months or more of FES, functional electrical stimulation, ergometry. Basically, you see the characteristics of the controls and subjects. They were fairly well matched, although some of the matching, because this was a retrospective study, was done in bigger categories than you would have wanted to. So we took T1 to T12, but there is a difference in between T1 and T12. And in the amount of T1s have some upper extremity impairment. They have less loading by the fact that they carry less things. A T12 will use a different chair. So there are some differences. But what I wanted to show you is that by MRI, this is our control group, and the white stuff is fat, and the black stuff is muscle. And if you truly look, and I'm going to show you the next one is actually a slide in which it would put the numbers on. But if you just look, you can see there is more black stuff in the subjects. This is muscle mass measured at the mid-thigh area. Now, the FES ergometer that we used stimulated the quadriceps, the hamstring, and the gluteus muscles. So we did look at muscle mass at the sternocleidomastoid level, which we used as control, because this wasn't influenced in any way by their activity. And then we looked and we compared we looked at the muscle mass in the lower extremity, and we compared the anterior, the medial, and the posterior thigh. We also, which were muscles that were actively stimulated by the machine, but we also looked distally in the calf area, where the muscles weren't directly stimulated, but they were stretched, they were moved by the pedaling done by the FES ergometer. So this is the data. So if you really look, the total leg volume is higher in controls than the subject. But if you look at the groups, the anterior, medial, and posterior thigh, and then gluteus is the gluteal. So anterior, posterior, and gluteals are all muscles that are stimulated by the ergometer. So obviously, subjects have increased muscle mass that is directly related to the stimulation. But also, let me see if I have it in here. No, I don't have it in here. And also, I have some muscle strength data that follows that shows that even distally to the directly stimulated muscles, we still have changes, positive changes. The SCM, so our control, internal control, didn't really show any difference. Total fat, so why is that total leg volume so high? Is because of the fat. Yes.
Sorry, we can't hear you back here. Would you please use the microphone?
Oh, sorry. Okay. These are kind of busy, but what I wanted to show you is that here, this is the quadriceps, this is the hamstring. These are all, both of them are stimulated muscles. Gastrosoleus is a non-directly stimulated muscle. And these are muscle strength. How did we obtain muscle strength in this study? For people that had complete paralysis, inability to actually measure, move their muscles, we maximally stimulated with electricity the muscle, and we compared the subjects with the controls. For individuals that had some muscle strength but were still wheelchair users, so they're incomplete, you can wiggle, you can stand up, but you don't use muscle, your lower extremities for functional activity, for usual walking, community ambulation. We measured all of the stimulated and voluntary contraction strength. So if you just look across, you see that everything that is this nice burgundy, which are our subjects, have increased muscle strength. So increased muscle mass, increased muscle strength, they're both important in bone mass density. So this is the data that we use to infer that exercise helps in bone mass in individuals with paralysis. Just a little bit about pharmacologic treatment. Only what it is applicable to paralysis, and I'm going to mention. The biphosphonates are being used. They are anticatabolics. Alendronate is the only study that was done in spinal cord individuals. It does stop the infralesional bone loss in men with acute and chronic SCI. Etidronate, pamidronate have been used in smaller studies. Zoledronic acid, which is a long-term, once every 6 months interval administration of biphosphonate has been studied in acute injuries. Dr. Shapiro here at Kennedy Krieger actually performed the study, showed less bone loss, no bone gain. The Forteo, the teriparatide, it's an anabolic, so anticatabolic stops the loss, anabolic increases the production. And then some others in very small, uncontrolled interventions, sodium fluoride, strontium, and hydrochlorothiazide, they all have been looked at in paralysis. So my treatment for bone health, look at secondary causes, measure vitamin D, measure estrogen-androgen deficiency, adequate calcium intake, 1 gram per day up to the age of 50, 1,200 to 1,500, thereafter also 1,500 for females that are pregnant or lactating. The adequate vitamin D intake is about 600 to 800 units per day, not the 400 that is in the common supplements over the counter, plus 15 minutes per day of sun exposure. Exercise, these are the ACM recommendations. Monitor bone density at the hip and the wrist, and if you want to do the spine, that's fine. But hip and wrist in patients with tetraplegia, the hip in patients with paraplegia every 1 to 2 years, and monitor the calcium and the vitamin D stores by looking at 25-hydroxyvitamin D as part of the annual well-being visit. And one of my quotes, so I can be up there with Dr. MacArthur, nothing will ever be attempted if all possible objections must be first overcome. That's that, thank you.